Hi all, today we will be discussing about attributable risk. This is a statistics class and it will just take 10 minutes hardly. So what is attributable risk? Let's see what is risk before seeing the attributable risk. Risk is the probability of an event. It can be a disease or a health outcome during a period. Suppose you are following up a patient for 10 years to see who is going to develop diabetes. So that is risk, the probability of an event occurring during a specific time period. What is attributable risk? This percentage of risk that you are trying to assess, it can be a disease or an health outcome attributed to exposure. Suppose the percentage of people developing diabetes who have had exposure to say smoking or say some X food or some Y environmental exposure. It can be anything. Okay. So, for example, this patient has had this positive test, and what is the percentage that the patient can go on to have a correct diagnosis, or you are giving some treatment, and what is the percentage the patient has had a good outcome because of this treatment. So, that will be your attributable risk. So, say this is the deceased patient. And in the deceased population, you see how many of them have had this specific exposure that you are suspecting led to this disease. And there is a small amount of population that do not have the exposure but still develop the disease. If you subtract these two, then you have your attributable risk. It's as simple as that. Disease in the exposed minus disease in your unexposed population. The other differences are, other names for this attributable risk, I am sorry, are risk difference and excess risk. It's called risk difference because basically you are looking at the difference between exposed population having disease minus unexposed population having the disease. If you want to calculate a attributable risk percentage, the percentage contributed secondary to this exposure to this particular disease. Okay. So, let us see in our standard 2 by 2 table. So, this attributable risk is ideally calculated in a cohort study because that is where you start from the point of exposure to point of disease. Okay. So, this is a table where exposed population are A and B and unexposed population are C and D. Among the exposed population, A have disease whereas B do not have the disease. In unexposed population, C amount of people have the disease whereas D amount of people do not have the disease. So, if you want to add everything together, A plus B is the population who have had the exposure. Does not matter whether they have the disease or not, just exposure. And C plus D are the population who do not have the exposure, irrespective of the presence or absence of the disease. A plus C is the population who are having the disease, does not matter the exposure. Okay. And here B and D are undiseased population. Okay. So, here you do not have how to say causality. When you represent something in a table like this, you are not saying this patient A developed this disease secondary to exposure. You just say this population has the disease, this population also has had exposure. But to know causality, you are going to do certain calculations like this attributable risk. So, let us see the risk of a patient developing the disease after exposure. Okay. So, people who have developed disease is A, correct, with exposure. So, that is A divided by total number of exposed population. So, this is the incidence of the disease in exposed population, correct. What is the exposed population? A plus B. Those who have had disease in the exposed population is A. So, the ratio is the incidence in exposed population. Similarly, risk of disease without exposure. So, the patient has had disease. So, who have had disease without exposure? It is C. And how many are people without exposure at all? C plus D. So, incidence of the disease in unexposed is C by C plus D. If you subtract these two, incidence in exposed minus incidence in unexposed, it gives rise to attributable risk, or in other words, risk difference. So this is attributable risk. What is attributable risk? Percentage. Attributable risk percentage is where you try to say the causality. You say that these many people have developed the disease secondary to that exposure. Okay. So you calculate that by dividing the attributable risk by incidence of the disease in exposed, or in other words, what will be the incidence of disease in exposed? A by A plus B. So whatever attributable risk you got here, if you divide the whole thing by A by A plus B, then you get attributable risk percentage. Incidence in exposed minus incidence in unexposed divided by incidence in exposed population gives rise to attributable risk percentage. Got it? So if you calculate an attributable risk percentage and say it is around 80%, and you have constructed this 2 by 2 table to see smokers versus lung cancer connection is there or not. So among smokers and who have had lung cancer, you can tell that 80% of the lung cancer is attributable to smoking, whereas 20% can be due to some other factors. But among smokers who are having lung cancer, 80% of the lung cancer is attributable to this risk factor, which is smoking. Alright, this is attributable risk and attributable risk percentage. So if you put all together, you can write the importance. What is the significance? You can calculate the magnitude of the causative factor on outcome. So you say 80% of this risk factor has resulted in the outcome or lung cancer, or in other words, the lung cancer has developed due to exposure to smoking, and 80% has contributed to the lung cancer. 80% of contribution is through smoking for development of lung cancer. Strength of association and causality, and assess effect of an intervention on outcome. So now this is something different, no? So till now we just saw causality. What is this intervention? You know that smoking resulted in lung cancer, but how do you know whether prevention of smoking will result in reduction of cancer? So for that you do something called as a population attributable risk. So this is done more in the scenarios of how to tell, health related studies, or wide intervention that you do in the population to prevent the spread, to prevent the spread of a epidemic or a pandemic. So you calculate something called as a population attributable risk, where the incidence in whole population is subtracted to incidence in unexposed, or incidence in unexposed population is subtracted from incidence in whole population. That will give rise to the effect that an intervention can have on the outcome. Suppose this intervention was introduced, or the cause was negated, say for example smoking was stopped. So what effect will it have on the population developing a lung cancer? So these are the importance of attributable risk. So whether there is a causative factor and it is related to it, what is the strength of association, and if I am going to introduce an intervention, what will be the outcome? The shortcomings of attributable risk being, this can be done only in a prospective study. It cannot be applied to a retrospective study, because you never know which is bias, which is actual contribution, which is actual exposure. And it is difficult to apply in a dynamic population who are going to keep moving, especially in a floating population, people who come to work and then go back to their native places. Then you cannot say this particular exposure is what led to the patient developing some X or Y disease, because the exposure might have been different for different subgroups of populations. I think if you write this much for an attributable risk, and if you understand this much for calculation of an attributable risk given to you in oscE or practicals, it should be more than enough. So that's it. We had a short discussion on attributable risk. Let's buckle up and do more discussions like this in the future. Thank you, all the best, and have a good day. Bye bye.